All right, so we're gonna go over the monitor today and some tips and tricks with the monitor, making sure that you guys have a little bit better familiarity with the monitor. Starting, if you open up the monitor, you're gonna find your cables and cords in there. If you grab your blood pressure, your pulse ox should be the same size as your blood pressure tubing. All right, I want it to be that way. Here's the reasoning why. I'm gonna attempt to do this so we can see this. All right, let me bring this up. People are gonna get sick when they do this. You don't have an end. That's interesting. Okay, so pulse ox. Where does the pulse ox go? Let's start with that. On a finger. Is there a specific finger we want to use? Ring finger of your non-dominant hand is where Massimo wants you to put the pulse ox. When I put the pulse ox on, does the cord go down the backside, sideways, or doesn't it matter? The backside. So the little picture of the nail bed is where your nail bed should be. All right. Dark red, black pelt, nail polish. I still take that stuff off. Massimo says it's really just the glittery stuff that you have to take off. All right. With that being said, how do I know I'm getting a good reading? What am I going to see on this screen that's going to tell me I have a good reading?
Good waveform.
Waveform. What else? Some of them are turned on, some of them aren't. So when I hit the monitor, I turn it back on. So the PI, so your pleth index is a scale of 0 to 20. Doesn't matter what the number starts at. You just want the number to be above 1. If your number's not 1 or higher, don't trust the pulse ox reading. What else do we get with the pulse ox? Heart rate. What else? SPCO. All right, where is that going to come up? Underneath. It should be a different color. I try to make it a different color and I try to keep it so it stays a different color. What numbers are we looking for SPCO? 0 to 5 is normal. 5 to 10 is a smoker. Somebody's been in the fire industry for 20 plus years. All right. So we're looking for that below 10, really. 10 to 14, nasal cannula and probably a ride to the hospital. 15 to 33, we're going to go high flow oxygen and a ride to the hospital. 33 and above, Massimo recommends hyperbaric chamber. I can attest that the ones I've transported from other places to St. E's for hyperbaric, their numbers have been spot on with what the monitor and their blood work is. They've matched exactly. So start with your ring finger and go from there. If you have a little tag on your cord, what is that tag for?
You need to use the pediatric water knob.
I try not to say pediatric. Try to say a small versus large. Because if I can slide my finger through this and I go to the base of my cuticle, I should switch to a smaller size probe. All right. Medic 2 is really a great place to stop by. Nick's probably going to hate that I'm saying this on the recorded line, but they have ear probes. Ear probes work great. Where does the ear probe go? On your cartilage. The E1 sensor goes on the cartilage of the ear. All right. What am I going to get with an ear probe? Just SpO2. You are not going to get CO with an ear probe. So if you're concerned about CO, make sure you're doing finger. If you're just need a SAT and you're going to monitor somebody, ear probe's going to work best. What is going to deteriorate faster, ear probe or your finger? For your readings on your monitor. Ear probe. Ear probe is going to drop probably 2 minutes before the pulse ox does. I'm not going to lie. I carry one with me. I've had mine for over a year. I just wipe it off and put it back in the package and put it back in my bag. It's a one patient use. It's not a one-time use, it's a one patient. Massimo hates that when people do that because this is $20 or $10 probe. There are reusable ones. Just don't use bleach on them. Be good to go. All right. Other questions about pulse oximetry? When you wrap the cord up, you always wrap it from the monitor, working your way out. If you wrap it the other way and do the traditional pulse ox wrap where you stick it in your hand, wrap it nice and tight, 6 to 8 months is all you're gonna get out of this Pulse Ox Pro. If you're curious, $450. The other piece is $450. All right. So big loops, as big as you can. Medic 6 is actually going to put a blue sleeve on theirs and try it out for a little while, just to keep their pulse ox and their blood pressure together. Any other questions with pulse oximetry? All right. Medic 6 took it ready. It's just a big.
I'm gonna be a medic. That's why I was just curious.
It's just a blue sleeve that goes over blood pressure and pulse oximetry. Yes.
What's this? Sensor fails indicate.
That is a good question. Probably that the sensor is bad. We've tried a different sensor here in a minute.
So not that important.
Oh, yeah, it's an extra one of these something.
All right, let's go to blood pressure. When it comes to blood pressure, does size matter? All right, how do I measure a blood pressure cuff? So I grab a blood pressure, I put it around, I got the Velcro to stick, I have the right size blood pressure cuff. No. How do I know I have the right size blood pressure cuff?
It's gotta be like snug on the arm and within the.
So first thing we're gonna look at is the range marker. Has to be within the range marker, all right? If your arrow is not within that range marker, you have the wrong size cuff. Welsh Allen will tell you you can be up to 40 points off on your blood pressures. They're at 110. We give another shot of nitro. Oops, my bad. That was 80. Hopefully it's not right sided MI. Make sure you're choosing the right size cuff. Upside down, right side up, or doesn't it matter? It matters. Right side up. The way the cuff deflates and inflates, that little button needs to be at the bottom. The way it draws the air out, it's going to affect your blood pressures. That's why it's a swivel. All right. Where do you put the bell of your stethoscope when you take a manual blood pressure? Below the cuff, over the artery. Why do we put it on an artery? So we can hear something, right? Because we're actually going to put the stethoscope in our ears and listen, right? If you're not going to put the artery marker over an artery, don't bother using the cuff. Leave it inside the bag. Put 120 over 80, a heart rate of 72, and a respiratory of 14. All right. You're going to get blood pressures that are all over the place if you're not going to follow those rules.
Quick question.
Yep.
You have so many large people that even using the forearm.
Yep.
Is that accurate?
Yep. Just remember your pressures are going to change from forearm to upper arm. I believe it's going to be lower, correct? Dr. Westphal? It's lower.
Not necessarily, no.
Not necessarily. Sometimes it can be different. Just make sure you document where you put it.
But no, not necessarily. It just reads it differently. Obviously, the leg would be different.
Like would be
I'm not, we treat blood pressure on the forearm the same.
the same rules apply. Just slide it down, artery over the artery marker. Artery should be good to go. Right size. All right. Changing the cuff, change the cuff itself. Don't change out the tubing. Hospital has the disposable cuff on. If it's the right size, go ahead and use it. So, what are the rules for the blood pressure system? Right size cuff, right side up, artery marker over the artery. It should not take you 5 blood pressures to get 1 good blood pressure. Now, if I put my 4 leads on, it's going to help my blood pressure. Okay? Questions about that? We'll move on to our 4 leads. If you grab your 4 leads out, they should be a big loop. It should not be a rat nest ball of mess. Again, starting from the machine, working your way out. Okay. Now, where do we put the leads? Where do we put the leads? On the patient we're trying to monitor. That's a great choice. All right. Level on limbs. All right. Zoll doesn't care. If you're underneath the clavicles, you're underneath the umbilicus. If your wrists, your ankles. You can't decide to do wrists and umbilicus. You change the box, you change your axis deviation, you change the way the monitor's going to look at the heart. So you have to stay square when it comes to the leads. Now, how many of you guys do skin prep? That's usually what we hear is crickets. I'm going to encourage you guys to pack a 4x4 with your electrodes. John's got Blue Dot SPs. Great electrode, except they suck with the X-series. All right. There's special procedure electrode. That's what SP stands for. Bound or AMBU will say, no, they work great, and we argue with them all the time. We'll swap out the leads and it works perfectly fine. You're gonna have to start doing skin prep with those SPs. Take a dry 4x4, brush the skin off, and then put that on there. Especially now that it's getting to be cold out, more dead skin, more lotions are on patients. Take a 4x4, pack it with your electrodes, that when you grab the electrodes, you grab the 4x4 also. Brush the skin off, and then put your electrode on. And doesn't matter where you go. We're also going to get your respiratory rate from your leads. Okay. If you have a simulator, go ahead, connect to your simulator.
We got a live simulator.
All right. All right.
Should connect to the
No, just do your 4 leads. Just do 4 leads.
digital. Yeah, we are. We're
Yeah,
connected to
connect
the
to 4 leads. You should be good. If the simulator doesn't power on, flip it over and push the batteries in, and it'll be good to go. All right. What are the 2 ways to print on the monitor? Okay, and what's the other one? Or a 12 lead. There's another one. Code summary. But there's 2 ways. If something goes funky on the screen, there's 2 ways to print. Camera button and the roll of paper are the 2 ways to print. What's the difference between the 2?
Well, if you just had
Camera
printed,
button's just gonna be this much, right? It's gonna be like what you see on screen.
well, the print button is just gonna continually print just the rhythm and then like
Until you-
your last set of vitals until you hit stop.
Okay,
The camera is 6 seconds, isn't it?
so close. 12 and 12. 12 before you hit the button and 12 after you hit the button. It saves to the printable memory of the device. I'm gonna say it again. It's a 24-second strip. 12 before, 12 after. Saves to the printable memory of the device. Just to be safe, I'm gonna say it one more time. It's a 24-second strip. 12 before, 12 after. Saves to the printable memory of the device. I can bet somebody here has ran a cardiac arrest and gotten 0 strips to print out on their treatment summary. How do I know that? Because they use the roll of paper to print their asystole, never use a code marker, never defibrillated the patient. They get 0 strips. If you get 0 strips on your reports, I know there are some medical directors that would love to have a sit-down chat and watch your whole cardiac arrest second by second so you can explain what goes on with it. I was just at a place and that's what their medical director is going to do is if you get no strips, they will gladly sit down with you and review your strips. So I'm sure here at Gold Cross, there are a couple of people that maybe will sit down and watch your cardiac arrest and go through your strips as it's live happening in front of you if you don't get any strips. I can't say it enough. Camera button, camera button, camera button, camera button. The more you use that button, the more you're going to get in your report. All right. So, roll of paper just starts and stops printing. Does not do anything else. If I get something funky and I miss it and I hit the camera button, but I don't want to print that strip off, I can just hit the roll of paper and stop the printing right away. It's still recorded. It's still going to land in my report. I should still be able to see it in my snapshots. It's just I don't have that 12-second piece of paper right in front of me, or that 24-second strip. I can print off my treatment summary. I can go to my vitals, and I can grab and print it off at that time if I need it. Move it there.
So when you put this on, when you start your P&B.
Yep.
Pads on.
It's continuously recording from the minute you turn the monitor on to the minute you turn it off, but you just have to watch it as a movie player. So snapshots record to your report, to your printable, your treatment summary, your code markers do, and your defibrillation or energies do. Does that make sense?
Yeah.
All right, because there are lots of people that never use this camera button. All they use is the roll of paper, and all they do is start and stop printing. Now, let's say I've got this waveform on the screen right there. We're done. We're done working this. We're all set to go. I need 3 strips, right? I can highlight I can select it. I can go down to insert. I can pick another lead. I can go insert. I now have 3 waveforms on the screen. What button would I want to hit? Camera button. I just recorded 3 strips on 1 piece of paper for my documentation. Instead of having 3 individual strips, I can put it all on 1. And then your 4th one would be your capnography that would be popped up there. Because you would most likely have capnography going. So that would be up on the screen. You'd have 3 assistantly and a capnography line. Okay. Remember, capnography auto-populates on the screen, so I should never have to insert it. So go ahead, highlight 1, scroll down to insert, add a channel.
I don't like I've done cascading.
So cascading is the same one,
Yeah.
2 channels. And then you can put, so you get, what, 8 seconds going across. Now, if you go to remove them, say I don't want them on there anymore, I want to remove them. If you select it and go down to remove, it will remove. You'll notice that if you try to do it to the top one, you'll never be able to remove the top tracing. The top tracing is always going to be an ECG tracing. It'll be never anything but that. Okay?
You could do.
Questions, concerns about that?
I was still trying to look.
No, you can't do it for the first one.
Like, she's gonna go right back to.
You have to hold 12 on.
Sure, go ahead and put your 12 leads on. So if I have 3 consecutive leads up on my screen here. Let me do this. Does that look bad? Am I concerned about that waveform? Looks like a science, maybe a 1st-degree block going on there. Nothing real worried about that, right? Now, am I worried about that?
No.
There's a difference between your home screen and your 12 lead screen. This is a diagnostic quality screen. Your home screen has filters and frequencies put on it to make it look pretty and bright. So once you go to 12 lead, you're now on a diagnostic quality screen. Now, you have your V leads on, connect your V leads off. I think Heather's back. We'll get there. All right. I have all 12 leads on the screen, right? You know, I did good skin prep. I got everything on the screen. What's the next step in our 12 lead process? Age and gender, right? So the clipboard. What's more important, age or gender? Gender is going to be more important. All right, now here, remember, we'll do age first. So if you select age, you don't have to hit it 45 times to get to 90. If you press and hold the arrow, it's just going to start scrolling up faster, and it's going to go faster, and it's going to go really fast. Same for on the way down. So just press and hold it, and it'll scroll away you go. So pick an age. It goes up to 150 if you're curious. All right. And then go to sex. And you're going to notice 2 choices, M or F. There is no other choice. Right? This is the one that usually gets me in trouble. Usually a phone call to HR or my boss. It's original equipment, not aftermarket. Why is that? All right, let me finish my statement before you go tell Mark that I'm being insensitive. All right, original equipment or aftermarket. What is different between males and females when it comes to cardiac? The heart, right? Heart's gonna be different. A female cardiac size is smaller than male cardiac size. So your elevation and depression for a STEMI is going to be different. So if you call it a male and it's a female and doesn't say STEMI, well, if you put female in there now, it's a STEMI. It's because of that heart size. Okay. So what does that do to us? That kind of puts us into an awkward position sometimes. Not as much as it used to in the past when Dr. Schrang was practicing around here. If anybody worked that long ago, we used to go to the Holiday Inn in downtown Neenah on a regular basis for bleeding. It was Dr. Schrang that had a patient that came in from wherever to have an operation done. Okay. So if you have to guess, try to guess correctly. Try to say, you know, something appropriate. Don't just kind of bluntly. So what was it? Were you born male or female? No, what heart do you have? Is it a male heart or a female heart? If you ask a transplant patient, they will be able to tell you the age, the sex, and all kinds of stuff about that heart. Okay? So just make sure you choose the right sex. I do want you to go in there and down to the last name field, and I want you to put the word test in there. Because we're going to send these 12 leads, and I don't want them to be activating the cath labs. All right, I hear grumbling already. Look at your left keys. You have row up and down, so you can go side to side and up and down. Clears the whole thing. Test. Let me tell Heather what's a 17, 12 is.
They should at least put like test in.
All right. So everybody got the word test in there? Or close to it? All right. Hit your home key. Get rid of your 12 leads. This was the first 12 lead we went into, and I went to take my 12 lead. I hit the camera with the 12, right? That screen is really blurry on the wrong side. Why are we so blurry? It's because Nick wanted to record this.
I think it's just.
Oh, there we go.
There it is. All right. So normally we come in here, we go on camera with 12, that box pops up, right? Put our age and gender in. Well, the minute you clear that box, it's going to start to acquire your 12 lead. If you use the clipboard, it's not going to. I like it when one person puts the leads on, the one person that enters the age. I don't care if it's a first responder, my partner, somebody can be putting that age in as we're getting in those files or getting in that song. All right. So now I want to acquire this 12 lead. What is the next step in my 12 lead process?
Camera about there.
Which camera?
The one on the top left.
Top left camera with 12, because I want to take a picture of the 12 lead, right? So I hit that camera with the 12. As this slides down. All right. So I take my camera with a 12. What happens when a 12 lead is taken? Does anybody know?
Capturing what's happening.
Okay, it actually takes 4 12 leads in a 10-second time frame, and then it's going to stair step print that 12 lead off. We start.
Nick just walked out there, so I blame him.
Supervisor truck. All right. So it takes 4 12 leads in a 10-second time frame, and then stair step prints that 12 lead off. The only thing we're going to use from 12 leads printed off, grab your 12 lead, look at your paper. I'm out of paper, so that's not going to work well for me, but that's good. You can use it. So look at your 12 lead, like all good paramedics, we look at the 12 lead first, we look at the rhythms. And we got, well, we got, 1, 2, and 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6, right? So the only thing we used from 12 lead number 1 was 1, 2, and 3. The only thing we used from 12 lead number 2 is AVR, AVL, AVF. The only thing we used from 12 lead number 3 is, we're gonna end. We'll continue the meeting. All right. The only thing we're gonna use from 12 lead number 4 is B3, 4, and 5, or 4, 5, and 6. Okay. Hold on to that little nugget of information here for a second. Now, when you see the word steady on the monitor, we're pretty darn accurate, Zoll is. We'll miss 1 out of 100. Still, read your strip like you're trained to. If you don't agree with what it says, argue with it later. Call it what you think it is going to be. All right? But make sure you read the whole interpretive statement. All right? Especially where the bracketed area is. That bracketed area is where the monitor pulled out the calipers and did the measurements. That's where it's going to say, hey, you've got elevation in V1 through V5, and you have depression here, here, and here. That's the monitor pulling out the calipers for you and doing it for you. All right. Any questions about the printout? All right, the second quick access key, that purple arrow. Hit that purple arrow 1 time. Here's all my numeric values. What are the important numbers on the screen that I want to look at on this page?
The PR interval.
PR interval, what else?
or certain-
STJ segments. So if I have elevation or depression in those STJ segments, that's where I can tell. Hit the purple arrow a second time. Go ahead, hit it one more time. Now it says snapshot 2 of 4, right? Remember I said we're going to take 4 12 leads in a 10-second time frame, and then we're going to print them out. Guess what? We're going to show you all 4 of those 12 leads. Go ahead and hit the roll of paper. I'm out of paper. And then compare those 2 12 leads and tell me if they're exactly the same or different. And I'll tell you if the configuration's been changed. Oh, I got more paper. Tear your 12 leads off, take a look at those strips, and tell me if they're exactly the same or different.
I don't think my paper fits in there.
They're exactly the same. So somebody changed it back. It should. I had it at the 314 hybrid. So what that would do is give you the ability to print off just 12 lead number 2 or just 12 lead number 3. So the next time these monitors get flashed, I'll be back to that. So you can do that. So you can walk in and say, hey, Dr. Westphal, here's my STEMI. And he's going to look at the one that you sent him and go, that's kind of garbage. But you can show him a good 12 lead. Because what happens to our patients? They move. They can't sit still for 10 seconds. But if I have 2.5 seconds that they sat still that I got a good picture of, why not use that 12 lead?
Plus the leads when it's steady, they're sweaty, they don't hold real well. I like that thing about the 4x4.
So we're going to I'll change it back to the hybrid mode so that you get that ability to print that off. Right? When are you going to do it? Crap, I just remembered I can do that. Maybe twice a year, 3 times a year, unless you're really diving into the monitor and actually into 12 leads really deep. Most people don't do it, but it's a great tool to have in the toolbox. Because we're medics, we like to have as many tools in that toolbox as we possibly can. Right? All right. I have my 12 lead. I've determined that this is a STEMI. What's my next step? Activate. So, making sure somebody knows. Because we're going to activate Pulsera if Heather says it's okay. So we got to go to Pulsera, right? Does anybody have Pulsera on their phone in here? All right. Use their monitor. What number is your monitor? It's Medic 9's truck. So what do we set up in Pulsera at the beginning of our shift?
Your that whatever that AR.
Yeah, we want to put our monitor number in there, right? Okay. 2101. Nope, 2101. You wouldn't want your monitor number in your. So on your strip where it says unit ID, that's what you want to put in Pulsera. It's 2101. All right. So we select that. But we gotta do something first on our monitor. What do we gotta do first with our monitor? We gotta send it up to the cloud, right? We gotta get it to Pulsera. So we use the envelope. So hit your envelope. You're gonna get a message on the screen with a bunch of hospitals. If you look at, oh, mine doesn't upload. Hold on a second. Let me. Does yours have a list of hospitals in there?
Yeah, my,
Does it have Pulsera as number
Yes.
one? Okay. All right. So you select Pulsera and you go up to transmit. You hit transmit. I have my green light going. Why do we have to do that? Or why should we do that? If you ever look on the other end of Pulsera, when you do a 7 on the 12 lead that you take a picture of, 9 times out of 10, it's upside down, crinkled, and they can't see it.
We can transmit them.
Yep, we'll transmit. You should, everybody should be connected to the internet in here. You should be able to transmit. All right.
Trying to connect.
How do I know I'm connected to the internet? Green wafers are on my lollipop at the top. And then I have my ball. And then if I'm not, I have my yellow dots. Did you guys go? Yep. All right.
Transmission.
All right. Now, and Pulsera.
I got it.
Okay, go. You guys got it over here? Go to EKG. Like you normally would take a picture and select monitor, not camera. There's your 12 lead. Now it's the PDF file that they can actually zoom in and zoom out on the other end. They can't manipulate the picture on the other side if you take a picture with it. So try to push it up. You do serial 12 leads on one patient. They're all in there when you upload. When you push them to the cloud, they all end up in there.
It's always fantastic for in the valley, but when, trust me, when you're.
Yep. So if you can push it, try to push it. If it's when you get to the hospital and you get a signal, push it then. Because then it's in the record and they can actually see it. It's a whole lot better than that picture.
It's really neat.
All right.
What orientation do you recommend holding the phone?
It doesn't matter if you put it up. I don't remember which way it's supposed to be when you take the picture.
Okay, last I had done it should be this way. If you turn it, then every time it shows up on a tablet, it's gonna be, yeah, so even though you want to naturally take it in the landscape mode, just take it in the portrait mode. Because you guys don't see it when it comes in. You're like, okay, wait a second. So you gotta go to about 45 degrees to go, oh, okay.
All right.
We can enlarge it.
You can enlarge it.
Yeah, it's really awesome how great you can enlarge it. You can really see the squares and everything.
So in there, where it says patient ID in your Pulsera, grab an ID.
Sure.
There you go.
Same.
Scan it. All your data is going to come into your phone.
It's gonna get them better.
Yeah, if you got an ID, passport, whatever, if you can scan it, it'll all pop in automatically.
Oh,
Man, you're old.
You learn something every day.
And you can scan it. It's like that.
Just doesn't put in pipe weight.
How many people are you?
You got now the correct spelling. You've got everything in there that you got. You're going to need their name and date of birth anyways. So if you ask for their ID, as a medic, we can do other stuff, but we could easily train our EMT partners to do that, to get that information in.
It's so easy. to
And you're
do.
scanning the back barcode.
The back barcode of a driver's license will do it. And if you have a camera on your tablet, PCR, you can actually scan and do the same thing and upload it in your EPCR. I believe we're on the version that has that enabled.
Wait, say that one more time.
So if you have one of those portable tablets,
Yeah,
the tough books that have the camera on it,
yeah.
if you scan the back of the driver's license, should populate into our EPCR.
Crazy. I like it.
Questions concerning with Pulsera and activating it. Okay. That makes it on the other end a whole lot nicer and a whole lot cleaner than some of the crinkled up pictures that we get.
Yeah, I didn't know that you could do that with these. I know in Ohio, we had that, but we never said to do it. I've been taking pictures that started 2 years ago.
Where do you select the monitor though on both?
When you set up the crew information,
Yeah.
you go to monitor and it should be in there. If your monitor is not in there, please let Heather know. Monitor, and when you look at a monitor to make sure that it's in there, you grab the piece of paper that prints off, look at the unit ID. The unit ID that prints off on there is what they're going by for Pulsera.
The one where it said unit.
Yep.
Not the big,
Nope.
not the big serial.
Not the serial number, it's the unit. She needs actually both. We fixed Medic 6s today, so they now can use that feature. And if you ever get a monitor back from service or a loaner monitor, make sure there's a unit ID attached to it. Because if there's no unit ID, it's probably not flashed correctly. So, well, your information in there might be, your configuration might be a little bit different. Questions, concerns about that? After today, moving forward, their configuration, if you go to device ID in the green gears, it'll actually give you a date, not a telephone number in the telephone spot anymore. So it will be today's date. So 12/15 of 21 is going to be the latest configuration out there. So after this next round, when they come through, we just put a date in there today when we did Medic 6s, so we had it in there. Any questions about 12 lead? Any questions about how to get people to do it? Steps of walking through to moving data. That's the key, is you have to have your green wafers. Envelope, select Pulsera. If you select the hospital, that's perfectly fine too. It's just gonna send a fax to a hospital. CNE's never hooked theirs up, so it doesn't work anyways. Theta and AMC would probably print off a 12 lead on their fax machine. Questions, concerns about 12 lead?
And then what do you do with it? I know.
It's all we're doing is trying to get it to Pulsera to make it work. Right, so if you accidentally selected a hospital, it's still getting to the cloud. You'll still be able to grab it from Pulsera. Okay, all you really need to do is grab Pulsera and you're all set to go. The only places that I ever looked at our 12 leads when we sent them, use it picking the hospital, was Theta. They're the only ones. Every once in a while, AMC would, but most of the time it was only Theta, and I don't know why that was, but they were the ones that were.
Save the vital signs. Or do we still have to punch those in?
It will attach, it should attach the vital signs with the 12 lead, or it is on the 12 lead when it is sent. So if you look at the PDF file, the vitals are actually on that 12 lead. But if you get more vitals, enter your vitals in there like you normally would. Questions, concerns about that? All right. Hit your home key or exit, get out of there. Problem number 2 I've heard a lot of lately. What's this?
In my
All right, chemography. How far do I turn this in? Quarter turn twist and only a quarter turn twist. People are trying to make this tight and they're not getting chemography readings. Back it off a little bit. All you need to do is find the trap door, push it in, quarter turn twist to the front. Okay. If you over tighten it, it's not going to work. So if your capnography is not coming up, back off your capnography a little bit, and I'll bet it'll fire right up. The other thing you have to do is make sure you turn it on. All right. If you don't turn it on and you complain that the capnography didn't work on that device, Heather can pull up that call and go, there's when you defibrillated. There's when you had your 4 leads on. There's when you took a blood pressure. You never turned on capnography. So it's not going to work. You have to turn it on to make it work. And again, quarter turn twist and only a quarter turn twist. Now, if I'm using nasal cannula capnography, how much oxygen can I flow through that capnography? Or flow through that nasal cannula? Max of 5. Anything over 5, you get washout in the sensor port. If you need to give them 8, put another nasal cannula in there. Double up their nasal cannula. Or if you want to give them 6, put a nasal cannula in there and don't run it off your capnography circuit. You want to give them 15, throw a non-rebreather over the top of it. It's that sensor port is where the oxygen is being delivered, is what causes the problems and get you the washout. Questions, concerns about that? All right. Let me get rid of some stuff on here as I do this. What numbers are in my capnography box now?
Before your entire 17 is your respiration.
All right. What is RR? All right, what's BR? That says BR up there. It doesn't say RR. What's the difference between a breath rate and a respiratory rate? Remember I said we'd get your respiratory rate off of your 4 leads in the beginning? Every time it sees the leads go up, it counts it as a respiratory rate. That's RR. Patients on the ground having a seizure. That respiratory rate of 240, is that accurate? No. The only thing that is accurate is capnography. Capnography is every time it samples air going through it or past it, it counts it as a breath rate. So breath rate's going to trump respiratory rate. So you'll see some monitors with respiratory on, some with off. Just remember, it's a good average if you're getting a respiratory rate off of your leads. The farther out you are with your leads, the more artifact you're going to get. That's why I'm a chunk person. I like my chunk. Questions, concerns about capnography so far? All right. If I don't get a waveform at all on the screen, what did I forget to do? Turn it on. All right. If you get this on the screen, purging, what should I do? Get my suction out and soft suction my patient. You've got something over your sensor port. Piece of noodle, a piece of meat, a lung cookie. Something is over that sensor port. A lung cookie.
Okay.
You never had lung butter come up and have to suction?
That's what I just.
Good old piece of tasty. All right, suction that off. You got 30 seconds to clear it off. If you can't clear it off in that 30 seconds, you need to replace your filter set. How much junk should I let go down my filter set? None. If I start seeing stuff go down my filter set, change on my filter set. John would rather have you go through 2 of these on a call than come back and say, hey, John, my bag is all full of fluid now. And you take care of it. Because what you did is you sucked fluid into that pump and pushed it out the inside of your bag. Okay? Or it's all over the inside of your monitor. And we have to send that back to Zoll. They have to take that apart. And that's about a $5,000 bill just sitting there, just open it up. All right. They have to open it up, clean it, take all the stuff out of it. Because there is actually an exhaust port that goes into the monitor if that outside one gets plugged up. So you start seeing stuff go down your filter line, change out that filter line. If you go to the hospital and they're on humidified oxygen and they're on a capnography, I will bet that the end of that capnography circuit is going to be yellow. It's going to have a little brass bar or piece of metal in that circuit someplace. That's for high moisture. And you can use them, it's just for high moisture. Questions, concerns about capnography? Again, turn it on, plug it in, quarter turn twist. Now, I have a good waveform on the screen. What do I want to do with that waveform? Is there a button I want to hit on the monitor? Camera button. Why do you want to hit the camera button? Because it records it. So that when they look at my strips, they see my waveform and my capnography waveform. I can walk into Dr. Westfall in the ER and say, here you go, doc. Capnography is 34. Here's my good waveform. I'm all set to go. So he can't come out in the ER and yell at me because the capnography dropped to 12 after we moved the patient over. I had my tube in the right spot. Here's my documentation that my tube was in the right spot. Something happened when we moved the patient. questions, concerns about capnography? Again, last thing you do before you move your patient, hit that camera button. There's your documentation that you have good capnography.
Isn't there like a warm-up time for the capnography too, like after you do the quarter turn? Don't you wanna leave it like a few
By the
minutes?
time, if you turn it on, plug it in, by the time you get to there, that pump is ready to go.
Is it, okay.
If you forget and you have it connected to your patient, over a minute for it to calibrate, and it may not calibrate correctly. It's sampling that dirty air. I want to have atmospheric air. Questions, concerns about that? All right. Code markers. Again, if we use our code markers, it's going to upload into our EPCR. I also get a strip attached to each one of those code markers. I get a 14-second strip. 6 and 8. So 6 before I hit the button, 8 after I hit the button. Attached in my report. And then I just have to go in the EPCR and fill it out. And there's 2 pages. You don't like what's on there, we can argue later and we go from there. Sync we'll talk about later. Roll of paper we talked about already. All right. Alarms. Limits. You'll notice at Zoll or at Gold Cross, we don't have any alarms turned on our devices. You can turn them on for your calls individually if you want, but there are no active patient alarms. If you're doing long distance transfers, it's a good habit to get into putting these in. It may be something that we look at doing down the road is putting in some parameters for some of these features. All right. Now here's the reason. Looking at my heart rate on the screen. What's your heart rate on your screen now? What's it say?
40.
Was it 60 to 120 or 80 to 120?
57, yeah.
So it should be 50 to 120 unless you get a button ready. So 50 to 120, right? Stat set, that top quick access key. What that does is it auto adjusts my alarm parameters 20% above and below what is currently on the monitor. So if I hook up my patient, do all my vitals, hit stat set, I now just customize the monitor to that patient. So if you're always doing transfers or there's a specific thing that we're doing, we can open up those parameters, turn those alarms on, have them really wide open, and then just hit the stat set button and customize them onto that patient. If it's Sally, and we know Sally is that, smoker on whatever's on Smith Street, her stats are 86, and that's a good day for her. And they have the alarm parameter at 90. Well, then we could just adjust that 20%. We don't have to listen to the alarms go off the whole time. Again, any of those alarms I turn on in that call, 2 minutes after I shut the device off, it reverts back to your department settings. The bell with the X, if I hit it once, up next to your battery symbol is a clock. It should be a 4-minute countdown, I believe. I get 4 minutes of quiet time. The bell over here gives me 90 seconds of quiet time. Bell with the X gives me 4 minutes, and I hit it one more time. I get the word on in there. And what on does is it turns on silence. Doesn't turn off your alarms, it turns on silence. You will still get visual prompts, you will not get any audible prompts. Does that make sense? All right. Green log. Let's go into log. If you got something on your screen, you can hit your home button, it'll get rid of it. The top clipboard. What does that top clipboard get me? Nope. That's my treatment summary. That's all my timestamps, all my strips associated with those timestamps. If you go down to print trends, what's print trends get me? All my vitals. So I can print that strip off. What I like to do is print trends, and then I print off my treatment summary, and then I have my vitals, all my stuff I did, and maybe I'll keep 1 or 2 strips and then I'll shut it off. That way I got that for my reporting or whatever I need to do with this. Or I can hand it off in the ER. But the one you guys use is which one?
A little
Envelope. So let's go to our envelope. So we have to close the case to push it up to the cloud. It can't be a live open case. Now, when I close the case, say I'm on an MCI, I've got 5 patients. I don't want to take manual blood pressures because everybody's, I don't know why I don't want to take them, but I don't want to take blood pressures. So I'm going to use my monitor to do it. I can close out the case and just so long as I know which monitor or which patient I was, which number, I have a new record. But all I'm doing is starting a new electronic record. I am not starting all my parameters over again. So what does that mean? If you took a blood pressure, my blood pressure was 200 over 90, and the next person you took a blood pressure on was 110 over 60, it's going up to that 210 first. And then it's going to come back down. Does that make sense? Because the monitor's always going back to that last blood pressure it's taken. Push it up in the cloud, go to the tablet, grab it, and bring it in. Questions about pushing it up to the cloud? You all good with that? Awesome. Garbage can, you can delete these monitors. I thought we had changed that, but Mitch made it back. Or somebody made it back. Your garbage can is not password protected anymore. It doesn't matter if you have a full monitor or an empty monitor. The speed of that monitor is exactly the same. It's not going to slow it down if your monitor is completely full or completely empty. FIFO memory, first in, first out. So that first case comes in, works its way down to basically 150. Maybe for Wapaka and New London, it's down to 100. All right. And then it kicks those old cases out.
I think the only reason we really used to use the garbage can was when we used to use the Wi-Fi upload. They used to try to pull
All
And
it
it
pulls
seems-
is the list.
It seemed like it was way slower, and then when you would clear it in the morning, it seemed to get uploaded. It feels
Yeah,
like kind of.
feels like thing. Yeah. It's a perception thing on that.
that.
So remember, don't get rid of your cases. If you're having problems uploading, make sure that that case is uploaded to the cloud. All right. The green gears are the green cogs. The only thing really you should ever have to go in here for is printer. If for some reason somebody orders the wrong paper and you now have red gridded paper, you'd want your grids off versus on. Okay. There are some things that start with F in here. If you change that things that start with F, you're going to F up the machine. Right? Filters and frequencies. If you don't know what you're doing with them, please do not change them. I can tell you Theta Star was down for over 2 days because their biomed changed some settings in here. So the minute they started to move, they lost their tracings on their monitor. They had nothing. It was all artifact. And what it was they changed a simple setting in here that deals with filters and frequencies. And I brought up my monitor, so you guys should have probably sooner. But went out there and I gave my monitor and we fixed the problem. All right. So don't change anything that starts with that. These monitors are set up for pre-hospital use. They are not set up for sitting on a shelf in an ICU or an emergency room or a cath lab. They are set up for motion. Questions, concerns about that?
Road noise and stuff.
Yep, they have filters on there for it. Your road noise that you get, especially now in these SP dots, skin prep is going to be your best friend. I can't tell you enough. Skin prep with those SPs. You're going to have to do it, especially now that it's cold. You get dry skin. Skin prep is going to be and right now it's whatever electrodes you can get. It's not like there's a whole big choice of electrodes out there right now because everybody's short on supply and supply chain stuff. So do not preload them. If you preload your electrodes about 2 hours after you preload them, you might as well take them off and throw them in the garbage. That's all they're good for. The bag open is good for probably, I don't remember what Ambu's is. I think they're 72 hours with the bag being open because of the humidity's gone from the packaging. Right? So try to keep that packaging folded up as much as you can, not open. Don't dump bags together, empty out the bag, and then start a new package. Because what happens when you dump packages together? Yeah, the old new mix. Now I don't have that. Now I use that same one for a week. Well, now I grab one that's 7 days old versus a fresh pack or fresh electrode. Questions, concerns about that? For you guys, just make sure you're in limited monitor. So if you ever go in there, it should say limited. All right. And I'll show you guys that later when we're not being recorded. All right. So, energy across the bottom. Do these look familiar? All right. I open them up, correct?
Once or twice.
Where do they go?
Take a picture.
All right, tell me where they go.
Control left,
All right.
remove the top.
Anterior, posterior pad placement, front and back. Which one goes to the front?
The back.
All right, I got one for the red to the back. What do you got?
Got this one.
Purple going to the back? Which one are you going with?
Purple on back.
Purple on back, but
Purple on the back?
straight.
All right. Dale's sticking, sticking with it, all right? Red to the rear. Red always goes to the rear.
Why?
Why? Biphasic energy. Why does it matter which pad goes where? That was my thought. So I was dumb enough to go up to our third floor at Zoll. You ever been to Zoll? Our third floor is where our scientists and engineers live. They don't get many visitors. So when you see a scientist and engineer that doesn't get many visitors, and they get one, see all the heads pop up in the cube farm. And they get really, really excited. They say, oh, rectilinear biphasic energy, we get our current up higher, fast. That's why I'm a good time. If you can spit that out pretty good easily. So Zoll uses the rectilinear biphasic waveform. So we have like a sawtooth pattern. We get our current up higher, faster. What defibrillates somebody, a joule or a current? Current. Joule is a time frame. All right. So current is what actually defibrillates somebody. It's the joule is the time frame. So I asked the question and they said, purple comes to the front because this is where your energy starts from. And then I want to take my red pad and put it on the rear right under the scapula. All right. So I sandwich that heart. So there's a lot of talk out there about dual sequential defibrillation, using two monitors and zapping people. What they're really finding with that so far, and I just talked to our Dr. Chuska the other day, I heard him talking, and it's really sounds like it's a vector change. It's really not the two energies at the same time, it's that vector change for that refractory VF. So we're doing this, and then we change to this. This is what really is doing it. Because nobody ever does a true double sequential defibrillation. You can't time it that you hit them both. It's usually a bang bang versus a bang. Right? So it's really hard to do that bang with that.
So
Right.
the problem is the two machines, you can push the button at the same time, but each machine reads it differently.
Exactly.
So particularly one on the AP have more fat. The one on the anterior lateral has less fat. So it reads the impedance. So each machine's gonna fire at a different time. You can't control that. You can push the buttons simultaneously.
And I'm not encouraging people here at Go Across to do dual sequential defibrillation. It's not in our protocol.
That's all right. Don't-
It's anterior, posterior. All right. Just because we're being recorded, I want to make sure that's said. All right. It's not in our protocols to do that.
Yeah.
But anterior, posterior pad placement. So when do we want to use anterior pad, posterior pad placement? There's three specific times I'm thinking of that we want to use in
Like
anterior.
if you have a piece and no piece pads.
Peds and my pads are going to touch. When else? Pacing. What's the other time I want to use anterior, posterior pad placement? Cardio version. Those are the three times we want to use an anterior, posterior pad placement. It's what manufacturers recommend. Doesn't matter if it's Zoll, Physio, or Phillips, they all say the same thing. All right. Now, I said, why does it matter? All right? I didn't even know why. So those scientists and engineers, they thought they were smart. So they said, do you ever see this package? I said, yeah. You ever see the Ziploc baggie on the back with the piece of paper in there? I said, yeah. Did you ever bother to look at it? No, why would I do that? I pick it up off the floor all the time when I pull the cable out. You know there's these things called letters? Do you know if you put letters in a certain order, they make things called words? If you put those words in a certain order, at this point I wanted to crawl out of there, they make sentences. If you would have read that piece of paper, even looked at the pictures on that piece of paper, you would have noticed that it says anterior, posterior, red goes to the rear, purple one comes around to the front. I just saved you 5 minutes of reading that piece of paper, looking at the pictures. You're going to do anterior, posterior pad placement, red to the rear, purple to the front. Now, the puck. What do we do with the puck? Separate it. When do we separate it? Every time we use the pads. Every time we use the pads, we separate the puck. Where's the puck go? center of the chest, nipple line, or where the nipples should be located, not where they're currently located. All right. Zoll ran Bill. You know, Bill's like 600 pounds, and he's down here at his knees. We're up here on the chest doing those chest compressions. All right. I'm gonna switch to training pads now. All right. So we get this waveform on the screen. Say I'm the EMT and my paramedic friend is nowhere to be found. What are the two buttons that every EMT here must know on this monitor? What's the first one they need to know?
Blood pressure.
Nope. The on button. They need to be able to turn it on and off. The second one is the analyze button. So grab your defib cable, connect to your simulator, that plug. Otherwise this doesn't work. All right. Go to VF on your simulators. Nope, you're good. You should be good. You should be good. All right. We good? All right. Hit analyze.
Stand clear.
If you're the paramedic, your ears just perked up. What was that? You're in the bathroom checking for meds.
Press
You hear
shock.
this button. You hear that noise. You hear the shocky button.
Perform CPR.
You hear that high pitched tone. You should probably hope your EMT partner hits that button or knows how to hit that button. So go ahead and hit the button. It's not working. Oh, charge. All right. Perform CPR. Now I'm in an analyze mode. I'm not gonna lie, I use this button occasionally here. All right. If I have a brand new EMT partner and I'm working with 4 other people that I'm doing all the ALS stuff, I lose track of time. I can put my egg timer out, I lose track of time. This gives me a 2-minute countdown and it's gonna say stop analyzing patient. I look up at the monitor, I can either deliver that energy or I can dump that energy. All right,
You dump it just by hitting hold.
we're gonna get there. 1 second, we're gonna get there. All right, before we get to dumping energy, I'm a paramedic though. I want to be in my ALS monitoring mode. How do I exit out of AED mode? How do I exit out?
The exit button.
Exit button, the top left corner that says exit. All right, I exit out. I'm back to my full ALS monitor. All right, if you want QA to be really impressed with your 2-minute time frames, use the AED mode. The only downside of it is I don't think they fixed the. It showed up as a 12 lead every time you did it in your report. So hopefully they figured that out. All right, now ALS folks, 1, 2, and 3. Those are our friends. Step 1 is we select our energy. So everybody select your energy. 200 because we do 200 straight across the board. Step 2 is charge. Step 3 is shock. Press the shocky button. The lower your battery is, the longer it takes it for it to charge. Okay. Now, my patient, go ahead, everybody hit charge twice. My patient gives me this waveform on the screen and starts talking to me. I don't want to deliver the energy to this patient. There are 3 ways to get rid of the energy. Wait 60 seconds for the annoying tone and high pitch gets really. Not a good friend of mine. Energy up or down, or the disarm key. Or you could power the device off, power it back on. Not a good career choice. Or you could press the shocky button and not tell anybody. Again, not another good career move. It's probably be your last cardiac arrest you run here at Gold Cross. Just saying. There's a problem with one of those. Energy up or down. If I use energy up or down, so everybody charge up, use energy to dump it. So you hit your energy down.
Oh, it stays
Stays at 150.
Yeah.
All right. So I'm now shocking at 150, unless I manually bump it back up to 200. Doesn't matter what device you use, Philips, Physio, or Zoll, we all do the same thing. All right. So you need to up your energy back to 200. Otherwise, you're going to continue to shock at that 150. All right. The best way to do it is use that disarm key. Best way is that disarm key. Questions about defibrillation? On your simulators, top row, second one or third one, doesn't matter to me which one you pick. You have this on this monitor. Your patient's pale, cool, diaphoretic, has a crappy blood pressure. We'll give them 80/53. What do we want to do with that patient? Synchronized cardiovert. So what's my first button I must hit? Sync. What three things just changed on the monitor? S's appear. What else?
You got the little dots on the.
Yep. And what else?
And your sync button.
And my sync is flashing, right? Okay. Step one is what?
Sync.
We got sync. Step two, energy. So what do we pick for an energy? Okay. Step three is what? Charge. What does the verbiage on your screen say? Press and hold. Remember, for cardioversion, we have to press and hold. I can't just press it and expect it to deliver the energy. I have to press and hold it to deliver that energy. Sync goes away just like it's supposed to in AHA guidelines. Questions, concerns about synchronized cardioversion? If you ever work with Van der Weyden, make sure you are up on your cardioversion. There's a good chance that you get to cardiovert somebody that shift. It wouldn't be my first time I've done that on shift. Third degree block, last button on your simulator. This is something we don't do a whole lot around here. It's happened every day down in Florida, but we don't get to do this too often down here. Patient is pale, cool, diaphoretic, has a crappy blood pressure. What do I want to do to that patient? Pace him. All right. So I hit my pacer button. What is my rate for our protocol for pacing? What do we start at? 70. It's pre-programmed in the monitor for us. All right. What's the next step when we want to pace? Start pacer. You have to go down to start pacer. Pacing is a two-step process. It has to be a two-step process. It's an FDA requirement. So I start my pacer. I go up to outputs. Go up slow. Please do not go up fast. Go up, watch it go all the way across the screen. Go up another 10. Watch it go all the way across the screen. Go up another 10. Watch it go all the way across the screen. People go way too fast when they're trying to get captured and they miss it. Go up by 10. You're going to get a pacer spike, QRS complex kissing. That's when I have capture. There's one that the batteries are getting a little low on the simulator, so you might have to bump it up a little bit. Once you have capture, hit your home button. This is your new home screen. Your screen should look like mine. Yeah, the batteries are going.
Yeah, I was gonna say, I'm like, I think we're a lot higher than we should be.
So I'm pacing this patient, right? You load up that patient to get out of the house. Pop one of your limb leads off. One of the four. Doesn't matter to me which one. Are you still pacing?
Maybe, yes.
Yes. On the Zoll monitor, you're going to continue to pace. Remember, pacer pads can only do one thing at a time. They can either look or they can deliver energy. They can't do both. Zoll is probably, I think, the only one that does this. All right. So you walk into the ER, the nurses rip off your electrodes. Go, hi, you're not pacing anymore. They peel your pacer pads off. Stick them to their arm or their leg or to somebody else. Who's getting the energy? They are. Quickly crank up the output, and then we'll have a conversation later because Dr. Westwall will yell at me. So connect the electrode back up. You would drop to a fixed mode for pacing. Just going to pace, add rate of 70, output of whatever you're at. Now go to normal sinus on your simulators. Am I still pacing? No, why not?
Spikes.
Okay, well, what happened to my rhythm change? The rate went up, right? So my rate's above what I wanted it to be set at. I'm set at 70. My heart rate's now 72. Should the monitor be pacing? No, we don't want it to be pacing. If you go back to that third degree block, what should happen? It'll start pacing again. That's the difference between demand and fixed. We good with that one? Good on how to explain that, the differences? Best way is pop that lead off and show them that way, and you're all set to go. You're at the hospital, you want to turn your pacer off. I hit my green pacer button on the bottom. I scroll down to turn pacer off. And away we go. Now we can turn over here and do whatever we got to do.
All of those settings we turn back.
So there, if I would start pacing back up,
Back to 7.
it'll be back at those, unless I have turned the monitor off for 2 minutes. So if something happens at the hospital and they can't figure out, you can just turn your pacer back on and go. Oops. Questions, concerns about pacing? All right. What is your dose of epinephrine for an adult patient in cardiac arrest? How do you know you give 1 milligram of epinephrine? Studied it. Got to play Johnny or Roy, right? We got to pop the tops, screw the syringe together, and I push the whole thing. There's nothing left of that syringe, right? What's your dose of CPR you give somebody? Knowing that that dose of CPR is a higher classification than that dose of epi is, what is our dose of CPR we give somebody? Well, that's the usual answer. I goes, what? What's a dose for CPR? There's no dose for CPR.
Like how many?
Higher classification. So let's come up with our dosing. So what are you going to go with first? 100 to 120 for your rate. What else? Depth. What's our depth supposed to be? 2 to 2.4. Right? How do you measure that? Everybody's guess is different. Where'd my puck go? That's what the job of this puck is to do. It's an accelerometer. It knows where it starts and it knows where it stops. What's more important, the compression or the release? The release. All right, that's what they think now is the release. All right, so let me plug this into here. And this into here. So what happens when we start doing CPR on a patient? We crack the ribs, but what else do we see on the monitor? Or who should be looking at the monitor? Person doing the compressions, right? That's why we put it at their hips. Plus it gets it out of the way for the Autopulse. There's my CPR dosing right there on the screen. I've got my depth, my rate, my release, and my perfusion diamond. If it's green, we're good to go. If it's yellow, change out that fellow. I want to keep it green. If my metronome kicks in, that's when I, as the paramedic, need to look at that monitor and figure out what's going on. That metronome's kicking in.
Push
They're
harder.
either too fast or too slow. I need to slow them down. I hear push
Good
harder.
compression.
Good. When was the last time you got a pat in the back and a little cardiac arrest? Good compressions. All right. Now, what happens when I put the Autopulse on? What does it say? It says Autopulse in that box, doesn't it? That way, when they QA it, it automatically gets separated. All right. Now, what do you see on the screen now? Is there a difference in those two waveforms?
Yeah.
So that second line is called a filtered ECG. We filter out up to 90% of what's going on the monitor. All right. So we can see your underlying rhythm. We can see a coarse VF. We can see an organized complex. We cannot see a systole. We cannot see fine VF. I still have to stop for that 3 seconds to verify what my waveform is. But I have a pretty good idea coming up to my 2-minute cycle what I'm going to be doing. Okay. I can charge my monitor up, still be doing those high quality, high effective compressions.
Good compression.
Thank you. I appreciate that. I got 60 seconds at a high pitch screw. I clear everybody, clear my compressor, verify my waveform, deliver the energy right back on the chest. Questions, concerns about using your see-through CPR or your dashboard for manual CPR? Doesn't matter if the first responders have it on, just go ahead and grab it and you're all set to go. Questions, concerns about that? All right. Any other questions about the monitor itself? Autopulse. First off, I come walking into a cardiac arrest. What do we do? As I'm walking in, what should be done?
carrying the Autopulse should open it up and take it out of the package, turn it on. Second person should turn on the monitor.
So if that person that walked in with the Autopulse is gonna be that person, right? Person that walked in with the monitor is gonna be the other side. It shouldn't matter if it's a firefighter that walks in from the city of Appleton, Needham and Ashland or Grand Street. They have the Autopulse in their hand. They should know that they should be dropping that Autopulse at the head and getting on that chest. Monitor person should be cutting the shirt off, getting pads on. I got some pit crew cards for you guys. Everybody gets one. Has the 2 and 3 person people on there.
Except that wasn't me.
Well, I wanna see the new cards. The one I have is a laminated thing that's bigger than that. So this is
That's the
awesome.
big version, but that's a small
Yeah.
version of it.
Yeah.
All right. Really get in tune with pit crew.
Yeah.
This is something that you shouldn't have to think about. Yesterday was a little shocking when only one person knew what pit crew was.
Have we practiced that so many times?
I spent many of hours in here being videotaped running cardiac arrest and having Dr. Westwell stand back
We
there.
cut through 2 dozen shirts to figure out how to cut the shirts the best way.
That was 2 days worth of sitting on the floor doing it. Pit crew is a well organized, choreographed of your cardiac arrest. It should be your first minute to 2 minutes of your cardiac arrest. It shouldn't matter where you walk in with the full-time fire department that's around here. It should all be the same way. And if it's not, stop by after a cardiac arrest and say, hey, guys, can we work on this a little bit?
The method by which you put the Autopulse on the patient, you know where that was developed? Right up there. Yeah, the picture approach we borrowed from Florida. I don't wanna over.
Collier County.
Yeah. However, you guys are on your way. You should always discuss who's getting what equipment, who's gonna do what, very important.
That first 2 minutes of that cardiac arrest is scripted, guys. You got to get that in your EMT partners' heads. I don't care if it's the EMT has the monitor and I got the Autopulse. That first 2 minutes or that first minute of getting that Autopulse deployed, titles go out the door. It doesn't matter who's in the room. It's a BLS skill. Everybody's BLS at the time. And I've worked cardiac arrest with Dr. Westfall in the field, and doesn't matter. We all do the same thing. All right. Dr. Westfall did much time on the floor with us. He's not afraid to get on the floor and back up what he's wanting you guys to do. He's done it. So really work on pit crew with your folks. Knowing those roles and responsibilities of what you're going to do is huge. It makes that cardiac arrest go so much smoother. Get Autopulse on, you understand what's going on with it.
It shouldn't be boring. It really shouldn't be boring.
Now, excellent point. Movement. That's what I need to get to, because we have a large problem of that here right now. We set ourselves up for failure. We do it every single day here. We can take a tour and go out to Medic 4's truck, and I'll bet they're set up for failure today. We're not setting ourselves up for success. We've got these split cases. People aren't folding them correctly.
We don't even have one on Medic 7. We don't have a tarp on it.
So you said the zipper case?
Yeah.
Yeah. So you could take a magnet mover and put it in there and fold it up underneath there, and I'll show you guys how to do that too. But we'll start with the quick case. So what's the first thing or what's one of the things we do at the beginning of our trip?
Change out some battery.
When I change out the battery on the pulse, what else do I do? Turn it on. What am I looking for when I turn it on?
Shows my hairs.
All right. No user advisories. I fix them if I have them. If I grab a battery and it's flashing at me, say this one is flashing yellow, what does that mean?
It's not charged.
It's not taking it fully charged anymore. It's only charged partially away. That's all it's going to be on that battery. It's not going to take a full charge anymore. If it's flashing green, what's that telling me? Your battery's 4 years old. Sorry, 3 years old.
Oh, really?
Yeah. Just tell me when your battery's 3 years old. You need to start thinking about getting new batteries. 5 year from the date of the battery, your battery's going to disable itself. It's going to shut itself off. 5 years from the born on date. Okay. How do I take a battery out? Sounds very childish, but how do I think about it?
Lean over and then pull the tab
What do I use to pull the tab?
and my fingers.
Fingers. No Leathermans, no pliers, no vice grips, no screwdrivers, no hemostats, no tools. It's black plastic, it's gonna break. All right, I'm sure I can find a bunch of batteries out here that have this tab missing. All right,
He's like brutal.
pull the tab and away you go. Now, the case itself. When you open it up, you want to set yourself up for success. There's 5 things you want to do. Get it to the head with enough room to work. That's step number 1. Step 2 is open up the case. Step 3, fans want something blue. I want to see white. I don't want to see any of the checkered. They're going to go on something blue, either the Autopulse itself or the tarp. My shoulder straps are out of the way. This one doesn't have shoulder straps, they're in the thing because this is broke. And my tarp is on the ramp. If you have that, you set yourself up for success. So tarp on the ramp. Not Velcro together, seeing white. Shoulder straps out of the way and connected. And I have 2 green lights. I sit the person up, slide them underneath it. I'm not big enough to do the foot in the crotch. So some people put their foot in their crotch, grab them and pull them up. I've never been successful at that. I've always had to hook underneath the arms. And that's what, when we did our training here, we found that it worked the best. Hook underneath the arms, sit them up, then you can control them a whole lot better. When you have your hand in that armpit, aim for the handle on the Autopulse with that hand. Because when you drop them down on that Autopulse, guide their head, just don't drop them. You're going to be in the right spot every single time. If you tap their butt to this bar on the Autopulse, you'll be in the right spot every single time. You're all set to go. You're going to get ready to move. Lift up underneath the legs, grab the yellow handle, give it a little pull. It should flake out from underneath them. If I do this and fold it like that, is that going to get out underneath that patient? No. All right. We want to make it so it's easy to come out. Waist belt straps. Take a little time, tuck them underneath the sides. Don't buckle them together. Yesterday, I was found 3 of them that were buckled together. So this is all buckled together. How do I get that buckle up when it's on the patient? Yeah, you guys stick your hand up underneath there. That's in an area where I don't want to stick my hand because I know what comes out there. All right. Tuck it underneath.
Did you say that's an EMT spot?
Hard to do that.
Take your time.
The waist belt.
Take your time, tuck it underneath the side there so that you're all set to go. So that when you grab the, you know right where it is, you don't even have to look. All you gotta do is just grab it and buckle them in. Now, what goes between the patient and the board? Nothing. We take the clothing from the waist up off. All right? Clothing waist up off. All right? We don't want anything in between there, so we're messing it up. Okay? Why is that? That black bar, remember there's 2 load cells in there. So the minute I move that patient on there, what's the device gonna do?
Recalibrate.
And then what's the device gonna do? Stop.
Pause.
The device is going to stop because that 20% reduction changed. 20% reduction is a patient safety feature. We're going to reduce that chest by 20% and move our blood flow that way. Okay? So, wait a minute, 20% reduction. We just talked about CPR and we have to do 2 to 2.4. What's my rate for CPR? We talked about that. That was 100 to 120. Why is the Autopulse doing 80? How it's doing its compression. So if you have a soaking wet sponge and you want to get the water out of it, you do this, you do this. Yeah, I'm going to squeeze that hard. I'm going to get more hard of it. When I do that sternal push compression, what happens to the heart? What's my goal with that sternal push compression? Just compress it, right? I'm going to try to compress it between the sternum and the spine. What does that heart have the ability to do in that chest cavity? Move around a little bit, right? So with the Autopulse, we keep it in one spot and we engage all 4 chambers when we squeeze that hard. We're coming down in on the heart at the same time. I get my compressions going. What's my next step after I get compressions going with the Autopulse? Nope.
Or I answer.
Nope.
Uh,
Shoulder straps. Shoulder straps go on next. All right. And then I get my patient secured. Which ones do I snug up first, yellow or black? Yellow. Where does the yellow one go? It goes to the yellow line. Black should be connected to your ear loops. Right? Then I get my seat collar on, and away we go. Get my tube in place, secure my tube. Questions, concerns with that? That head's bobbing up and down.
Pillow or blanket.
Pillow or blanket, take the head down. Do what you gotta do. Okay? Questions, concerns about that? Now, what do I review with people? Oh, yeah.
Really doesn't like that nobody else is in the room. More cards.
You can look through, you can look at mine, I'll get you down on every. Okay. All right, I might have one more in my back here. Quick reference card. So what you should talk about on your shift with your partner is that card right there. All right. What's the first thing? I got more someplace. So the first thing on there is, what is the first one thinking of?
Yellow line goes under patient's armpit.
What's the next one?
Yellow tag goes in center patient.
And then when you do what?
During that being searched.
Make sure my bands aren't twisting straight up and down. All right. Device stops. What am I going to do? Read the screen. I'm going to pull up that life band. When I pull up the life band, am I pulling it up slow and controlled, or like I'm starting a lawnmower? Slow and controlled. What we see here a lot is people pulling up like a lawnmower. What happens to that drive shaft? It doesn't get back to top dead center. So it never resets itself. It doesn't know where home is. It's got to know where home is. All right. Pull that life band up, slow and controlled, stop at top dead center, set it down. Do I touch the band as it's sizing? No. If I push on the band, what do I do to my load cells? I change what it's going to do. It does probably what, 1 or 2 compressions and stops, if that. If I hold resistance to the band as it's coming down, I change the pressure on those load cells. What does it do? 3 to 5 compressions and then stops. That's not what I measured. I can't do those compressions. All right. Hands off of the band. Treat it like you're going to defibrillate your patients. Questions, concerns about that? What's the next one underneath there? I think I covered them all except for one. Shoulder straps. When do I put my shoulder straps on? Sooner than later. Which ones do I snug up first? Yellow. And then what's the next one underneath that?
Okay.
Hold the case. When I wrap up the tarp, I don't like my bands Velcro together when I'm using this case, because my luck, it's me and Molly and the patient's 400 pounds. I'm not going to be able to pull them up or be able to hold on to them real well. We get them sit up and we go, crap, we forgot to undo the Velcro. So now she's holding on to one side, I'm holding the other side, we're trying to get the Velcro off. Because the 4 firefighters that are standing there are going, huh, you guys got problems? Or the supervisor's standing, you need a hand? Yeah, we need to get this undone. Even if you forget to separate them, you can at least get them undone. So I do Velcro this way. Shoulder straps. This one has them in here because the thing is broke. My waist belts are nice and secure underneath. I find the end of the tarp all the way over the top. Fold it back in half. Fold it back in half one more time. And then one more half. And now I'm all set to go. If you've ever followed me, you're going to find that your bottom 2 handles, the bottom buckle is fed through it. Reason being is if something happens and this opens up a little bit, that tarp is not going to become a huge tail. Buckle them together, and then I make sure I got my trauma shears in there. Questions, concerns about this? We're gonna go take a field trip out by Medic 4 and see if they're back. And we're gonna look at their truck and see if it's set up correctly.
Or 9, because 9 doesn't be right.
Oh, 9's set up correctly. I believe 9 is. I know 8 is. Let's go take a field trip. I don't know how to stop the recording. Let's stop the recording here. And Dale, or not Dale, I'm gonna Dale. What's his name was here yesterday? Boyd was here yesterday. Boyd was here yesterday. So. Here. Then we'll come back and have a sandwich. Nobody got a sandwich.
Thank you, Danielle. I'm probably one of the few that have been to
I remember coming, big call to headquarters, and all of a sudden they say, go to training room. There's bro, okay, cardiac arrest all, and we do our videotapes, cardiac arrest, and then we review it. There's sandwiches here, there's, banners, there's beverages, there's ice in the other room. Grab a sandwich, and then I'll wrap up with my last two little bits.
Are they gonna send you to San Diego?
For EMSP? No, I didn't get that one. I go to Puerto Rico though.
It's Puerto Rico.
Critical Care Society
I can take that.
in February. So
That one they don't.
that one's gonna be a good one.
You know,
EMSP.
Indiana's good, so it's really a work one anyway.
Yeah.
We don't want it in San Diego or in Puerto
Puerto
Rico.
Rico.
San Diego's tough enough.
Where's it at? It's at the convention center, isn't it?
Yeah, well, it's at the high end.
Oh, the Hyatt. Well, that's right attached to the
Yeah,
convention center. isn't it?
no, the big convention center, different spot.
Oh, is it?
No, Hyatt has their own
Oh, they're all
small convention center.
I was just out at Town and Country for, it was a public safety hospital EMS cardiac survival summit. So I went to that. That was all in one building, nowhere near anything. I mean, there's a mall right behind it, so you could at least walk in there and some restaurants.
Yeah.
So,
San Diego's okay, my wife's gonna go, because the weather's not bad. The alternative site they have is in Austin, she won't go to Austin in January. Nor do I
Finally,
want
an
to.
alternative.
Well, they all rotated,
Oh, okay.
they rotated. And then they just added,
Oh, and the Jackie
I think it's Tampa, which I'm sure she'll wanna go to.
I know we were in here.
No, I didn't. Thank you.
It's there. Thanks, guys, for putting up with me for 2.5 hours.
They put up with me for about an hour.
That's a little over 2 hours actually, but that's okay. We're not. If you guys have questions, call me. Please send me an
I'm
email.
gonna have to rewatch the video to get through everything on the monitor again. That's a lot of.
So really enforce that blood pressure thing with them. Your pad placements and pit crew are the 3 biggest things that can ask that you guys get out of here. And the last and most important is make sure your autopulses are set up correctly. Make sure they are ready to go. I'll ask John if he's got them, he's got more. Because hopefully you guys, this Gold Cross is gonna be one of the first sites that gets the new Autopulse. I'm working very, very hard on my end to make this be one of the first sites that gets them.
What would you like? Like pretty similar?
A lot simpler, easier to use. There's no load cells, they're not gonna stop, it's gonna be great.
What helps when people don't work out?
So please, all I can say is make sure the stuff is ready to go on the trucks. If it's not there, if you're missing equipment, write it up that day. All right. Don't wait 5 days for somebody to write up a missing on a pulse case. Because then you make your partner cry. And it's then Mark and Nick get phone calls. It's I made somebody cry again. Make sure you got your equipment on the truck. And encourage your new hires or the people that you're working with that if you leave something at a hospital, make sure you go back and get it, or make sure that somebody's going to go get it for you and not wait 5 days and realize that it's not there and then go to that hospital and not grab it while it's sitting there. I end up making people cry over stuff like that. Because remember, this Autopulse is about $17,000 worth of equipment. 1.7. The cardiac monitor list price is about 35, between 30 and $35,000. Gold Cross spends a great amount of deal of some really good equipment for us. If you treat this like a $17,000 piece of equipment, not like a $2 trauma shears, it's going to last us a lot longer. So what do I mean by that? If it's not in a case, get it in a case. It can't rattle around in an ambulance uncased.
What
You
would
are gonna
do
damage
if you
stuff.
had a MacBook. Treat it like a MacBook,
Treat it like you bought it.
you know?
Like you paid that $12,000 or $17,000 for that piece of equipment. I mean, it's cost more than my car does. And encourage your crews to treat it that way. It's really frustrating coming in and seeing equipment that we worked really, really hard to get here and put a lot of time and effort into making this stuff the best that it can be. And how it's deployed and the poster on the wall. We are still talked about all over the world because that CERT clinical trial. There's a lot of stuff that came out of that trial that we are known for. Our names are attached to that.
I know that they have, you find people will put this on the back of the cot. They'll have it maybe on the cot, or we'll have a empty chair, on the bench, and they'll bolt belt it in. Would it be something that Gold Cross would benefit from to get, I know there's mounts, to click them inside something.
Mounts are all personal preferences because there's all kinds of different shapes and sizes. Some you have to add a plate to the bottom of it. Now you add more weight to the monitor. Yeah, granted, it slides in, locks in, locks in on a pole. The only thing I can say is making sure it's secured. If you're going to put a seatbelt through it, hold on to that seatbelt when it goes through. Because we had a rash of, I think it was 4 or 5 monitors where we shattered screens. We actually had somebody riding along and they hit the button, released the thing, smack, shattered the screen right in front of the QA guy. He goes, I know why they're breaking. And that's not a cheap fix to replace that screen. That's why you'll see some that have the jack flap. We call them the jack flaps. Because Jack Hill didn't want screens broken. So that was not as tight as the E-Series was. And we all know how we love the E-Series one. That was so much fun. But yeah. Questions, comments, concerns? Was this worthwhile?
The pick food thing and happening like on a regular basis. Is that what we were getting at before? That goes well.
Well, testing. We call Greg in and
So if you guys don't want to get to that point again, you're the FTOs. You're the ones that have to get people to know pit crew and understand it. If cardiac arrest times are starting to gradually increase or we're having problems with it, don't be surprised if they come back with, hey, we're going to run some cardiac arrests. And you end up coming in and maybe it's just Heather and a video camera. Maybe it's Dr. Westfall and that video camera and Heather or Lauren or whoever. I will tell you the most unsettling cardiac arrest to run is in this room with Dr. Westfall sitting there watching you. It is the hardest cardiac arrest to run you'll ever run in your life. Because you're looking up at him because he's very, very stoic. He won't hint at all until you're watching the videotape. And then it's like, so why did you do this? Walk me through that. And you have to have good rationale of why you did it. Otherwise, he'll give you his rationale of why he wants you to do it at this point.
Most of the time, mine also works.
I remember those days here. Whew. So I had to go do them. Seattle, Rialto, Lawrence Douglas, Naperville. Those are those guys that are doing that, what they call Rialto or ACR stuff now. You know, it's just a different way of running a cardiac arrest. Seattle's big into your cardiac review, your cardiac arrest reviews.
I'm just surviving.
Well, so when you say Seattle, Seattle cherry picks their numbers. They use the Einstein criteria. When you can say Rialto, they use all comers, but they do things really different. The Rialto model, there's 7 different things that they do in the Rialto model. Naperville has adopted that, and they've got the highest ROSC rate. Their ROSC rate is over 50. I think their last one was 53%. Their last quarter, they ran 13 cardiac arrests. They had ROSC on all 13 of them. 6 of them walked out of the hospital neurologically intact.
What are they doing different?
So the first thing they do is get them on the Autopulse. Second thing they do is put them on a stretcher, elevate their head to 30 degrees, throw in the rescue pod. Next, they intubate the patient at that 30-degree elevated position. So if you think about it, if you have a stretcher and you have the patient on that stretcher and you go to intubate, first off, think back to the last time you went to the OR to do your intubations. What's the first thing they asked you in the room? Or what did you do in the room? You raised or lowered the patient, right? We have mechanical cots that have buttons on them that can raise and lower my patients. It's feasible to get the cot in there. Cot in, put them on a stretcher. All right. Now, the next thing they do is they intubate, and then they start an IV. Person that intubates is the person that starts the IV. Reason being, their theory in it is delayed epinephrine. They don't want to give that epi yet. Because when does AHA say we're supposed to give epi? Early and often, right? Is the new guidelines. So what is early? Let's think about that for a second. Call comes in. First of all, they got to get recognized that they're in cardiac arrest. Somebody has to make that call. We'll say dispatch takes 2 minutes to enter that call. I don't know how long it actually takes them, but we'll say 2 minutes. They tone it out. Go across dispatch enters that call. We'll give them 2 minutes. Or maybe a minute because they got their stuff. I'll give them 2 minutes. How long does it take us to get to a call average? And we'll say it's in the city. 5 to 7 minutes. You're now at what, 12 minutes? Is that early? Yeah. All right. So what happens if we prime that heart first? Do that good, high quality, high effective compressions. What happens? Yeah. All right. Give that. What happens to the heart when